Welcome to Health Tech Nerds. Would you start by introducing yourself and the company?
It's a pleasure to be here, Martin. Love what you guys have built with this community. So great to be on here with you today. Vijay, Kedar, co-founder and CEO here at Tomorrow Health. Our vision at Tomorrow is to restore the home as the patient's primary place of care. And we do so by providing frontier technology to coordinate across the home-based care ecosystem.
Great. So when I think about durable medical equipment, I sort of think about the stores in my neighborhood that have, a storefront and they sometimes seem to be open, sometimes seem to be not. Can you talk a little bit about what exactly durable medical equipment is and what distinguishes that from non-durable medical equipment?
Happy to. So generally talk about DME or DME POS, which stands for durable medical equipment, prosthetics, orthotics, and supplies. And collectively, I would think about this as the breadth of equipment and supplies that are needed to enable patients to manage healthcare safely from a home-based setting. So it's everything from the capabilities to enable a senior to age in place, grab bars in the shower, wheelchair ramps, basic mobility equipment to enable management of activities of daily living, walkers, wheelchairs, rollators, but also gravitating up to some of the more complex types of equipment needed to manage more acute conditions in the home. So, oxygen, portable and stationary oxygen, ventilators, BiPAP machines, hospital beds at home, and perhaps the most complex, power mobility wheelchairs and custom prosthetics and orthotics. So these are types of equipment that are intended for repeat use in the case of DME and are intended to enable a patient to be able to manage their healthcare conditions from home safely and effectively.
And what's the current state? So, like I mentioned, in my neighborhood, we have a DME store. What what is the current state of the ordering process for that? What does it look like today?
Yeah, it's today very fragmented and inefficient. So, one of the analogies I like to make is that this ecosystem is probably 15 to 20 years behind the pharmacy ecosystem in terms of how it developed. So, if you draw back the clock 20 or 30 years, you look at pharmacy. First, you have this really wide breadth of independent pharmacies throughout the country. Those have since consolidated into more national franchises. You have really manual ordering processes. So you'd go into a pharmacy, they'd go back into a manila folder, put your prescription in from the physician, tell you to come back in a couple of days once they've processed that. Now we have digital rails and e-prescribing to help manage that process much more seamlessly. Um, Before it was all stationary pharmacies and retail. Now we have digital pharmacies and mail order. And then, of course, we've seen over the last couple of decades the development of the benefit management layer to manage the payment rules in the ecosystem. And I would think about a similar progression in the DME ecosystem, except a little further behind. So, this ecosystem of providers and suppliers is really diverse and really fragmented. And that's largely because DME reimbursement, particularly from Medicare in the 80s and 90s, was super generous. So it became a really attractive small business opportunity. And because there's so many types of equipment, and a lot of this needed to be held locally from a retail inventory capacity, it created a lot of different types of DME organizations that would just manage a certain type of equipment. So some for mobility, some for oxygen, some just for supplies. Uh, and without digital rails or a clear uh, prescribing standard, processes were all over the place. So, ordering a particular type of equipment would often have a very bespoke ordering pathway based on the specific rules and requirements or paperwork that hospital system had, a DME supplier leverage, or the insurance type. And it's compounded by the fact that there is just so much complexity in this space, right? DME is an area where there's over 3,500 HCPCS billing codes, over 100,000 products and SKUs, and differences in insurance benefit designs across tens of thousands of insurers. So if you think about doing that manually and in a bespoke process, it leads to just a tremendous amount of inefficiency. And to tie that in, what that has looked like is generally, ordering providers, sending faxes out to about half a dozen suppliers. Um, Generally, what takes about 15 to 17 manual touch points and phone calls back and forth to collect the right information. All in, it takes about 90 minutes for a referring provider to place an order, and it can result in days or weeks long delays to get patients the products they need. So that was the original status quo in the industry from an ordering standpoint.
That makes sense. And so, can I talk, or can you kind of talk me through the various stakeholders in the network? It seems like it's actually slightly more complicated than pharmacy prescribing. So you have insurance companies, you have the vendors, you have the ordering providers. Is am I mapping the network correctly?
Yeah, so we think about it as four main stakeholder groups. So you have the payers that determine the payment rules and structure the networks. You have the ordering providers, which in this space is pretty diverse. You know, inpatient discharge managers, outpatient physician groups, even all the way down to post-acute facilities and home health facilities that are ordering DME for members. Then you've got the ecosystem of suppliers, which is a couple thousand suppliers across the country, and then of course patients. So those are the four components of the ecosystem.
And InsureScripts was setting up the e-prescribing network for the US basically. They had some tailwinds in terms of the high tech legislation basically mandated a standard. That was the standard that they were using. And the economics worked out because pharmacies were really interested in getting order flow uh, of prescriptions. I'm curious. It feels to me from the outside that DME is sort of lacking standards, and there's still, as you mentioned, a lot more of the like faxes and paper. So, what is it like building a network in an environment where there's sort of less standards, less formalized regular processes? Like it seems to me like you'd have to build all of that yourself.
Yeah, so I'll break it down into two components. One is, what's been the necessary infrastructure that we and others have had to build and create to digitize the ecosystem. And then the second is, which I think you were implying from the network development standpoint, how do you go about bringing these ecosystem players together? How do you bridge that chicken and the egg gap when you don't have standardized processes or a unified regulatory framework? Um, for the first question, it's really been two key pieces of infrastructure. So the first is a unified clinical rules database. So internally, we call that our CARES engine, Clinical Automated Rules Engine. So I mentioned the breadth of HCPCS codes, payer benefit designs, which suppliers have otherwise had to effectively kind of memorize as tribal knowledge over the years. We have leveraged advanced data analytics and machine learning to codify those millions of permutations into a proprietary data asset that ultimately guides for each insurance benefit design, all the way down to state-specific, waiver requirements for DME for a particular HCPCS code and product. What are the insurance questions that need to be answered? And what's the information that our ordering provider needs to supplement in order to justify reimbursement for that product? So it's really creating that unified baseline of payer rules. The second is creating a digital interoperability layer to replace the manual and analog processes that happen today over fax and over the phone. And that has, developed in this space from manual processes to traditional e-prescribe. We have advanced that with our AI ordering capabilities, which have leveraged LLM-based workflows to streamline that process. But fundamentally, it's creating digital touch points between ordering providers and suppliers, leveraging those payer rules in order to take what was 15, 17 manual processes and create a digital transaction with integrations on both sides with EMR systems and ERP systems for suppliers. So those have been the two components of the infrastructure that we've worked to build over the last couple of years. And then it's about how do you get folks to use that? Because, unlike the pharmacy space, we'll talk about it a little bit later. There are regulatory pushes to greater standardization, but this ecosystem, like most, they don't have the same leverage that the pharmacy and the PBM ecosystems have to drive regulatory change to force a standard across all providers. And so that adoption really has to harness the incentives of each of the parties involved. And for Tomorrow Health, we started first with the health plans because the health plans wrote the rules. They wrote the payment rules. They determined which suppliers are in network and what were the reimbursement rules that would govern the types of equipment that could be provided to patients. And so we started partnering with health plans. And as we had conversations with health plans, we heard two things from them. One, we heard, this is a black box from a quality standpoint. And so if you can help us really kind of leverage your technology layer at Tomorrow Health to give us visibility, standardization, and a bit more control over this very diverse, fragmented network of suppliers and DME products that we have, that would be immensely value add. And then the second was if we could really kind of create incentives in the ecosystem that promoted high value care delivery. So delivering products faster, servicing patients better, delivering high quality equipment. So we started with the health plans, and through health plans, we leveraged joint communications to onboard providers and hospitals. We onboard or engage with a wide breadth of suppliers in their network. And so that's how we began expanding the business. Interestingly, what happened next is we were rolling out our technology to ordering providers who were taking, what used to take a 90-minute process and now being able to order through our platform in under 60 seconds. And they were saying, hey, I'd love to use this, not just for this one insurer, but for all of the patients that I serve. And we were getting inbound from hospital systems and provider groups in other geographies saying, we need a technology solution in this category. And so we began democratizing our provider technology to start adopting, bringing on and activating providers first and payers second in certain markets. And collectively, through those entities, we've built a really strong relationship with the DME supplier community today, where we have over 3,000 supplier locations active on our platform in a full national network with the full breadth of large nationals in the space, all the way down to regional single location mom and pops providing care. So for us, that was the journey of first building the technology infrastructure that was necessary to digitize an analog space through our CARES engine and the interoperability layer, and then navigating what in healthcare is always that complex chicken and the egg problem to really take 3, 4 disparate stakeholders and bring them together, all unified behind, what we're all certainly oriented as the North Star, which is the patient experience and enabling those patients to get products faster. Collectively, what that's resulted in through our work with our customers is for health plans being able to drive a 4x ROI through our work together and cutting down the time it takes patients to get care at home by over 85%. For ordering providers, taking what used to be a 90-minute process, cutting that down to under 60 seconds. And for one of the health systems in our network, saving them over 50,000 frontline clinical hours per year from that ordering efficiency. For suppliers, by giving them digital clean orders and automated processes, we have reduced their operating costs about a third for a number of the suppliers on our platform. And from the order volume they get, many suppliers have grown their businesses 2 or 3x. And then critically, for patients, it's resulted in translating what used to be a -10 or a 0 NPS score in the category to an over 95 patient NPS.
This is, I think, an interesting moment because there's a lot of attention in Washington D.C., which is where I live, on the regulatory side of things. And one of the things I noticed in the home health rule is there was a sort of more talk about DME than usual. It looks to me like the two biggest changes were the competitive bidding process and then some interoperability mandates that had come out of a separate rule. Can you talk through what change is afoot regulatorily?
Yeah. Well, I start by saying I think, some of the activity in this space mirrors what have been two consistent policy priorities for this administration. One around reducing fraud, waste, and abuse, and ensuring that Medicare dollars and government dollars are spent with high and effective ROI. And then secondly, as we know, this has been a very technology forward healthcare administration. And so leaning into interoperability, leaning into digital processes and protocols to drive greater efficiency and transparency in the healthcare ecosystem. And so, first on the cost saving and the fraud, waste, and abuse side, the biggest update in DME is that after what has been a gap period, CMS has restarted the competitive bidding program in DME. And what that is effectively kind of a wide scale procurement process for Medicare fee for service to determine who are going to be the subset of suppliers in each category and each geography that will be given the bids to supply DME products for Medicare fee for service. And while that is really about the fee for service spend, which is pretty significant in DME, a lot of times that tends to drive consolidation or market share for those suppliers in other insurance business lines as well. So it's pretty significant as a process. And, um, prior rounds of competitive bidding have had big impacts on the industry. They've traditionally driven more consolidation. So this industry has had about 2 to 3 waves of consolidation on the supplier side. And then they expectedly have brought reimbursement down. So there are really kind of 3 key tenets of that process for this upcoming competitive bidding. The first is that the clearing price for reimbursement is going to be set at the 75th percentile of the winning bid this time around. Secondly, CMS has created a simplified bidding process, streamlining some of the financial documentation requirements that are needed, really to enable smaller providers to be able to compete alongside bigger ones. And then the last piece, and this is probably the most significant, is this upcoming round of competitive bid has really primarily focused on dropship DME items. And so this is notable because, we've really seen kind of a bifurcation, an increasing bifurcation in DME over the last couple of years between products like oxygen, ventilators, hospital beds that require in-person servicing, and those products like supplies, urology, catheters, CPAP supplies, and others that could be drop shipped effectively to a patient's home. And so this competitive bid really focuses on the latter with an orientation around continuous glucose monitors, which have been a high cost area, off the shelf orthotics products, and then other types of supplies. From a timeline standpoint, CMS is providing education to the supplier community right now and through the middle of this year. The bid window is expected to open in mid 2026 with bids placed in the fall, and then awards being provided in 2027 with the expectation of care transitions from losing suppliers to winning suppliers happening before 2028. So big dynamic for the supplier community and the industry. And then the second one I'll just touch on briefly. So we have CMS competitive bidding to reduce fraud, waste, and abuse and reduce cost. And then the second is just some of the interoperability mandates. One of the more notable ones is obviously around the electronic prior authorization through API requirements and requirements around faster and more transparent prior authorization decisions. That's pretty important in DME because a large proportion of higher cost items in this space require prior authorization. And so it's one of those things that is pushing downwards greater digitization of the otherwise manual processes in the space. And we believe that is going to lead to greater digital adoption and more effective interoperability.
I'm a little bit curious to hear, so on the waste, fraud, and abuse front, it feels like DME there's this delicate balance that you have to do because if you're trying to root out waste, fraud, and abuse, it's much easier to just have a handful of large
Mm,
suppliers who
yeah.
are, big, easy, soft targets for a DOJ investigation. But you also want a competitive, like I said, my neighborhood DME supplier is like a part of the neighborhood. I'm curious, sort of philosophically from your perspective, how do you balance those two things? How do you balance the desire to have a robust, independent supplier community while also being able to be aggressive about waste, fraud, and abuse, which I think in historically DME has been one of those areas where there's been a bit more waste, fraud, and abuse than other areas. So yeah, I'm just kind of curious to get your view on that.
Yeah. Well, I'd tackle it by really trying to understand why has there been this amount and perception of waste, fraud, and abuse in the space? What are the root causes of that? And then how does that translate to this balance you were mentioning between fewer, bigger suppliers versus a wider, more diverse range of smaller suppliers? I think first thing I'll just say is it certainly in our experience, the vast majority of suppliers we've worked with in this ecosystem are incredibly ethical, patient centric, and deeply focused on regulatory compliance. So unfortunately, a lot of the bad rap has been driven by a handful of bad actors that have exploited some of the opacity in this space to drive what have been, really meaningful kind of fraud episodes, right? And we've seen those every couple of years. Operation Project Brace was one, $2 billion orthotics scam. We've seen really kind of big challenges in skin substitutes and other areas. So it's a small set of bad actors driving really high volume scale fraud, waste, and abuse. I think one of the core reasons the space has been susceptible to it is because there have been so many manual workflows and because so much of the care is delivered outside of a hospital setting, so in a home-based setting, there's really not a lot of great visibility to actually ensure these transactions are happening appropriately. So, how do you know if it's a paper-based prescription that, it's not a provider that is being compensated to provide more DME prescriptions, right? If you digitize that, you can monitor data and prescription patterns. That's a little different. But when it's manual and analog, it's hard to see. When DME is being delivered to millions of care settings across the home, you don't know if a senior has received, the wheelchair or the supplies that Medicare is being billed for. And then one of the challenges has just been the volume of supplies billed, right? Sometimes, patients will complain about, getting, 12 months more of urology catheters than they had needed based on, a procedure that required it. And so, how do you modulate the amounts of resupply that are being provided in the space? So, I think some of the opacity and the care setting has enabled and facilitated that. What do we think are the solutions to enable that? Greater digitization, more transparency, more visibility, and putting upfront in the ordering process a clear validation of the rule sets to determine that orders starting at the point of prescription meet the categories that are needed, right? Are the right standards of resupply, meet the clinical criteria so you can prevent some of these issues downstream from happening. So how does that take us then to what's the right balance in the supplier community? We have always believed that a diverse community that promotes competition is best for patients because we've seen incredible capabilities from large national suppliers to invest in integrated technology and greater diverse capability set. But we've also seen some of the highest performing suppliers in our platform through our data analytics around patient quality and satisfaction be local regional suppliers that have built real relationships in their communities and invested in high quality care. So we think the solution is empowering all those supplier types with the right technology and capabilities to provide DME in a way that's above board, right? Where they can keep up with the compliance requirements, they can keep up with the paperwork, they can keep up with the documentation, they can keep up with the CMS audit requirements and scrutiny that are there for a good reason by leveraging technology and tools and being able to be on the same even playing field with larger organizations that have the resources and capability to do that, right? Like with any regulation, there's a lot of debates and discussion around this as it goes around AI policy today and other areas where, more regulation, new regulation often favors, groups and organizations that have more resources to invest behind that. And so, we think some element of a level playing field through technology can help the ecosystem and ultimately patients get the best of both worlds here.
That makes a lot of sense, and it seems to me like as the operator of the network, you're in a unique position to, sort of facilitate a marketplace which is beneficial for you as the operator, but also to the rest of the marketplace, which has that kind of healthy competition. I know we're coming up to the end of the time, so the last question I wanted to ask you, if we can squeeze it in, is home-based care seems to be like the home as the site of care seems to be one of the themes going into, as we start the year of 2026. I'm curious what this looks like beyond DME. What is what are the other, what is like the sort of the next logical progression from being able to order DME through Tomorrow Health?
Yeah. Um, we really think about it in 2 to 3 different phases, right? So the first focus is getting patients the critical, equipment and supplies to be that foundational infrastructure layer to manage care at home. The second wave is around kind of direct services, right? So we think about home health services and home care services, skilled therapy like physical therapy, respiratory therapy that often builds on top of the equipment that patients have in order to enable them to progress effectively in managing some of these clinical conditions. I think, especially for seniors and those who need support with ADLs, home care has become, a massive need in this country, and one that's growing dramatically with 11,000 folks aging into 65 plus each day. So we see that next wave as really around services. And then, the third tier is, okay, how do you facilitate and enable a more acute level of care in the home-based setting? And, we think while it's been great to see the momentum around things like hospital at home, our perception has been that the regulatory frameworks and some of the incentives and the payment rules in those spaces have not really enabled that ecosystem to grow. So we think about more acute level care, not on a holistic episodic basis, but really about how can you horizontally get patients the different breadth of equipment, supplies, at some point medications, infusions, and others to really facilitate management of more complex conditions in a home-based setting. Because at the end of the day, the home is where people want to be. 90% of senior citizens want to age in place, but it's also, in my belief, one of 3 or 4 levers we can really drive to reduce total cost of care in the country. At the end of the day, a year of oxygen therapy at home for a patient is the cost of 1 day in the hospital. And so leveraging that cost arbitrage for the system more broadly and enabling a care setting where people want to get their care, I think is one of the highest value things we can enable in US healthcare.
When I worked at or Colorado Medicaid, we referred to the local safety net hospital as the most expensive hotel in Denver. It's just the way that the economics work. This has been great. Learned a lot. We'd love to have you back again soon to talk through some more of this, especially as the year goes on. But thank you so much for your time this morning.
Always happy to, Martin. Thanks so much for having me on. Great to see you.
Have a great day. Bye.
You too.
Do